Thank you very much, and thank you to Hanyang University and the Digital Healthcare Center for this invitation to speak at your 8th Open Forum, all the way visiting from the United States to share my work. So I will start by defining some principles on health equity and digital equity frameworks. I will share 2 examples of some of my work that focus on using digital platforms and electronic medical records solutions for low-income immigrant populations in New York City who experience language barriers. The focus will be on Chinese American populations. The first study is a participatory approach to developing a web-based app for Chinese American patients to access in-language, culturally tailored early childhood mental health resources and information. And the second study is on co-developing electronic medical record-based tools with doctors and patients on gastric cancer prevention. And I'll end with some key recommendations on how to use an equity focus for digital health interventions. So I'm going to start by sharing some of the methods and frameworks that guide my work. In 2015, our section for health equity that I lead articulated an approach for population health equity. It draws on 6 different approaches. In the middle, it's anchored by the socio-ecologic model, and this recognizes the multiple levels of influence. So the individual, the patient level, the community around that person, institutions like the healthcare system, and then political systems and the environment, like for example, the government and the government policies around healthcare. Related to that, I also use a social determinants of health framework, so understanding the social factors that influence health, a life course perspective, community-based participatory research, so engaging with patients and communities to co-develop interventions, and to bridge clinical practice and community-based health promotion. So the idea that to really intervene and to promote healthcare should not happen just at the clinics or hospitals with doctors, but it should be at the community level. So healthful information and education in the school systems or at churches or through community centers. Much of my work in the United States is also focused on working with populations that experience health disparities, so largely immigrant communities. And to reach this group, you need to make sure that the information and interventions work with that person's language as well as their culture. And so I use a transcreation approach. And transcreation is from the commercial marketing, so commercial communications. And it's about adapting interventions or messages for communities or populations where you're focused not on the words, translating the words, but on translating the meaning and the culture. So for example, in mental health, there's a depression checklist. And one of the questions in the US is, do you feel sad? Do you feel blue? And to feel blue is a American phrase about being sad. So if you were to do a straight line translation, you would just translate the word blue, the color blue. And so for some communities, some populations, that they don't know what that means. So being blue may mean that you can't breathe. So it's not getting at the same thing that you would be getting in the US. So instead of translating the words, you translate the meaning. So you translate, do you feel sad? And what does sad mean in that culture? And using that term. We also need to think beyond technology and the user-centered approach. User-centered approach can really focus on usability and feasibility of your innovation, but we need to think beyond that towards a human and equity-centered design. So meaningful, contextual investigation and engagement of all the users of that piece of digital tool. So not only the patient, but also the doctors, the health system or the hospital, as well as community leaders. And at that level of human and equity-centered approaches, you can then get at some of the other features around acceptability, adoption, and then eventually impacting health equity. This is another way of thinking about a digital health equity framework. We want to also understand the context in which the intervention or innovation happens. So you want to think about the individual or patient level, interpersonal, community, and a societal level. So this figure itself has in the middle the digital environment, which can include electronic health records, smartphones, patient monitoring through patient health records, and digital health sensors. And the digital determinants of health work across these levels of influence. And the digital determinants of health can include someone's access to health tools, whether they have strong Wi-Fi or broadband, how well they use smartphone tools or digital tools, and the community infrastructure, like they're being able to access the internet and other tools. So for example, at the interpersonal level, it can be whether a doctor may be hesitant to recommend that a patient access the patient health record portal because they think that that person does not have high digital literacy. So maybe if they're working with an older adult, they may say, oh, they won't know how to use that patient portal, so they won't recommend it for use. So that is an example of interpersonal level influences on being able to access digital health. So as I explained, so I wanted to present on specifically on the Chinese American immigrant population in the US. And I think, again, we have to think about the different levels of influence. So I want to provide some context about who Asian Americans are in the US. But before I move into that, I also want to share some societal and policy level context in the US and maybe how it differs in South Korea. So in the US, we have a mixture of private and public health systems and public and private health insurance systems. And our hospitals and ambulatory care, so ambulatory care is like a clinic or a community clinic or doctor's office, while a hospital could provide surgeries and a more in-depth health care. These two entities, hospitals and ambulatory healthcare centers, have different electronic medical record systems. So in the US, there are top 8 electronic medical record systems for hospitals. 3 systems represent almost 70% of the market. The number 1 is Epic healthcare system. For ambulatory care, there's 15 different systems and that represent 70% of the market. So we're trying to align across a lot of different electronic medical record systems. In 2022, only 57% of the US population actually accessed their patient medical records, so their patient portals. And there are disparities in who accesses those patient portals by race, ethnicity, education level, income level, access to the internet, and language. In South Korea, you have a single national healthcare system and one national health insurance program. And my understanding is that this is in the works, but there will be one patient healthcare portal, which is the My Healthway app, which will be introduced. But there's 90% adoption rate of EHR systems across the hospital and ambulatory care institutes here in South Korea, and 93% of the adult population owns and uses smartphones. So differences between how the healthcare systems are set up. And similarly, in terms of immigrant populations, 14% of the US population are immigrants, but South Korea also is now rapidly growing their immigrant population, so it makes up almost 5% of the population, and they have varying degrees of limited fluency in the Korean language. So Asians in the US are the fastest growing racial ethnic group, and they now make up about 7% of the total population, US population, and their numbers are projected to continue to increase. Related to socio-demographic backgrounds of Asians in the US, Asian American data is always presented in the aggregate, so Asian American, and not by the individual Asian groups. And when you present the data in the aggregate, you lose important information on the differences and disparities across Asian groups. And so a lot of my work in the US is the importance of looking at specific Asian groups or specific ethnic groups in the data sets to really understand how to better reach and work for those communities in terms of increasing their health outcomes. So these are just some of the differences. The average median income is $86,000 US dollars for the Asian American population, but you can see there are several groups that fall well below that number, including the Chinese, which are at 82,000. Same patterns for poverty, where we see that about 10% of the Asian population experience is at the poverty level. And then there are several groups below that, including the Asian, and then the Chinese group is at 13% experiencing poverty. And we see similar patterns for education, where the average percentage of Asian Americans who have a college degree or more is here, 54%. And then we see that Chinese Americans are a little bit higher than that at 57%. But then you have, again, this disparity, large differences for other Asian groups. And this is also true about English language proficiency. Several groups experience high levels of English, limited English proficiency. The average is 72%, but we see that the Chinese American population is at 61%, and many groups are below that as well. So language is a key factor in reaching these populations. So just to sum up that section of slides, despite the rapid growth, Asians are poorly understood and understudied in the US. There's a lack of disaggregating the data by Asian group. And despite this fact that the US federal legislation prioritizes that data be disaggregated, we're not seeing that happen in the actual research. And 0.17%, so less than 1% of the overall budget from the National Institutes of Health, which is our federal government that funds research, less than 1% is allocated for Asian American research. And so this means that there's a severe lack of interventions and programs that really address health disparities that affect Asian Americans. And then in terms of this talk, I wanted to focus on digital health equity with a focus on the Chinese Americans, but there are several factors that facilitate and serve as barriers for Chinese Americans and other underserved groups in using digital health tools. So digital health literacy, or the ability to use and access digital tools, is one factor. Design-related components of digital tools, like knowing how to navigate that tool, knowing where the button is to enter information. Some of that design-related components is important to factor in. Translation and the availability of tools in different languages affects one's ability to access and use digital tools. Representation of culture, so seeing yourself in that tool or that program, and knowing that what information comes out is meaningful to you is really important to embed in any digital health tool. And tools that address security and privacy concerns, especially in the US with working with the immigrant population, there is concern about how much information is being presented and used and available for the hospital system as well as the government. So those are large concerns that you need to think about in developing these type of tools. So I'm going to go into the first study. This is an ongoing study to address early child mental health wellness for Chinese American families, where we used an equity and user-centered approach to culturally developing a digital tool. So this study was initiated with our community partners that serve the Chinese American population. There was real concern that there wasn't translated information for young Chinese American families on how to identify problems, mental health problems, or problems around early childhood education for their children. That was translated, that they felt like they could follow, and that they knew how to actually put into action. This was a concern from the community members, but also a community health clinic that we work closely with, and that's the 7th Avenue Family Health Center. It's part of our NYU Langone Health Network, and they serve 80% of their patient population is Chinese American. So the overall study goal was to use a participatory approach to design, build, and implement Our Child, which is a web-based app to increase access to early childhood mental health information and resources. And again, our priority population was the Chinese American immigrant families in Sunset Park, Brooklyn, which is Brooklyn's Chinatown. We had several partners that we worked with on this project. They included the Center for the Study of Asian American Health that I lead, colleagues in the Department of Child and Adolescent Psychiatry, the Digital Solutions team, so our MCIT team, our IT team at NYU Langone Health, the Community Health Clinic, 7th Avenue, and then there's a Sunset Park Community Coalition, so a community partner that's focused on early childhood development, a larger community of community partners, our web app developer, so this is the company that we worked with to actually who actually developed the app, and then the parents and providers that we worked with. So our first aim was to design, build, and pilot Our Child. So we've completed all of these 4 steps of aim 1. We conducted a mixed methods early childhood context and needs analysis. We did participatory user design sessions with families, doctors, and the staff at the clinics, and with community partners to inform what to put into the app. We adapted and built a digital library of in-language information that we made sure that was culturally tailored for the Chinese American population. We piloted the beta version with a cohort of 12 parents, and then also with the providers who receive care, who serve the 7th Avenue Family Health Center, and then we use that information to refine the tool. So aim 2 is to actually implement the tool with about 120 families, so 120 parents and their child, and then to apply a mixed methods approach to evaluate the outcomes of using that. So not only using the web-based app tool, monitoring and tracking to see what they're looking at, which pages are accessing what information, but also a qualitative study, so interviews with both the parents as well as the doctors to understand how they use the tool. So this is information from our qualitative study, so the focus groups and interviews that we did, as well as the user design sessions. So in this first row, we asked about what are the concerns parents have, what are the family members, what are they concerned about with their children, and we identified 11 domains, 11 source pieces of information that they were very curious to learn more about. The one that really stood out to us that came directly from the parents was the fact that the parents felt like they didn't have enough information on the New York City education system and how to access New York City early childhood programs and special education programs. And so we had to develop that information from scratch. In the second row, our focus groups and interviews confirmed that parents, instead of a standalone app that they had to download onto their smartphones, they wanted a web-based app. They wanted to be able to look at it on a tablet, on a desktop computer. They wanted to be able to share it with their parents, so the grandparents who also help to look after the children. So they wanted it to be a web-based app, which is what we use as the starting point. They also wanted it to look familiar and to mimic the way the Chinese language apps that they use look like. So they wanted it to be colorful. They wanted it to have the same functionality. And so we also took a page from that and really looked at the existing web-based apps that a lot of these parents used. And then we affirmed with doctors and parents how to link it to the electronic medical records, how the doctors wanted to get that information when they met with the parents and had a clinic visit with them. And the parents, again, had strong worry about confidentiality and who would see the information and what was presented. And so we use that information to help inform what the summaries and what ended up in the electronic medical records look like. So our multidisciplinary team, which included a early childhood psychologist, we worked on the 11 domains that we learned from these interviews. A lot of information did not exist for this population, so we had to translate and transcreate that information so that it was relevant to these families. And we created over 100 individual pieces, mostly videos, short videos, or short tips, information tips sheets, which is what the parents wanted. And we use, again, a participatory approach throughout the process. So we continually met with the IT group at our institution, the vendor, the web app developer, Kwon, as well as with the healthcare providers and communities and patients. And this is just a high-level user flow. So the overall project started with the recruitment of patients, having them log in and start to access the information. So we actually built in an initial survey of what information that parent was most interested in, and delivered directed health information through the app to them. And then we had them do actual validated early childhood screeners, so healthcare screeners, to then identify problem areas and again direct information to them. And those screeners, is the summary of the screener data is what the providers then saw, and that was in their electronic medical records. So we did flowcharts for the doctor and how the doctor would access the information, and how the information would be available during checkup, and that it would help facilitate discussion between the parent and the provider on some of these challenges or problems that may have come up in the screener, and then how it would then link to a referral to an early childhood specialist or other services. And then again, we use that information that we collected to inform what the summary information from the screeners would look like, and then that went into the to the EPIC electronic medical record system. And this again was very important because we heard over and over again that the parents were concerned about what type of health information would go into the electronic medical records about their child's mental health. And then we did 2 separate workflows for using the web-based app altogether, and then what the health clinic saw. And I just wanted to now shift a little bit to how we worked with the web-based app developer, Kwon. So this is the initial draft of the design that the app developers came up with, so draft 1. So you can see it's very, very boring. It's absolutely something that our hospital liked, but parents aren't going to like this. It looks boring. It's not engaging. And so we told them, please go back and make it more colorful. And they came up with draft 2. And so they added a little color. And we said, no, this isn't what we're hearing from our community partners, from the patients themselves. So then we showed them examples of parenting apps that these parents were already using. But again, the information is all from China, so some of it is not relevant to the US context. But this is what these apps look like. And so we said, we want to integrate some of this to make it very familiar to the parents so that they understand how to use it. And so this was what we came up with. So we retained features of the healthcare system so that it worked for the institution, but then we also introduced colorful and cartoon-like images. We used zodiac symbols, so if the child was born in a specific year, that animal, that lunar character came up. We used the same kind of color pattern that they were interested in, and used more icons. And then just to highlight, this was draft 2 of what the vendor came up with. And this is our final version. Again, embedding many videos, which we heard from our community, from the patients, that they really wanted more videos and short pieces of information. And so this is the user journey. So you log in, you take the first survey about what information you're interested in. We immediately deliver that information to the parents so that gets them engaged through these curated articles. And then we call them quizzes, but these are the mental health screeners that they took. And then it would then summarize those findings that went to the doctor as well. And included, actionable steps for the parents to take, as well as delivering a content to help them make those changes. So currently, we're still in the recruitment phase. We want to recruit 120 parents into the study. We're actually probably at about 80 parents now, and we plan to be completed by December and then start the mixed methods evaluation. And so some of the things that we want to do is to continue to use that evaluation information to refine the web-based app and to think about how we can use it for other information as well. The second study I'm going to be presenting on is a study that we recently completed, and this is on gastric cancer, focused on H. pylori treatment for Chinese American immigrants. This study was initiated directly from input from our 7th Avenue Health Clinic partners. They were seeing high rates of H. pylori infection and very bad treatment outcomes. So they really wanted to introduce some kind of intervention to help their patients take their medications to completion and eradicate H. pylori infection. So H. pylori is a bacteria that grows in the digestive tract. It's present in over half of the world's adult population and is a grade 1 human carcinogen and the strongest risk factor for gastric cancer. But it doesn't equally affect all populations. So there are health disparities exist for the Chinese immigrant population compared to the general population in the US. Chinese American immigrants have high rates of infection, 47 to 66%. Gastric cancer incidence is high in Chinese Americans, and in New York City, if you look at the deaths due to gastric cancer for Chinese New Yorkers compared to the city overall, it's almost twice as large a death rate. So in the US, there are guidelines that for treatment by the American College of Gastroenterology. The guidelines state that all patients with a positive H. pylori test should be offered treatment. After treatment, they should be tested to make sure that the H. pylori infection is gone. And antibiotic history, so the treatment is triple antibiotic therapy. Antibiotic history should inform what treatments are actually delivered to the patient, because there is high rates of resistance in some parts of the world. But in practice, these guidelines are not implemented well. Checking for eradication is not routine in healthcare settings in the US, and often clarithromycin triple therapy is widely used even if that person is coming from a country with high antibiotic resistance rates. So you have to think about the actual therapy that you're actually prescribing for those patients. So we decided to do a 2-armed randomized implementation trial. From our conversations with the clinic, we knew that they needed to implement multiple levels of interventions. There was the fact that the patients themselves knew very little about H. pylori, their risk for gastric cancer, and that they didn't understand the medications that they were on. We also knew at the health systems level, we needed to make it easier for the doctors to prescribe treatment, as well as to make sure to follow up with testing. And so we conceived of an intervention that had multiple layers. The first layer was a health systems intervention using the electronic medical record system to facilitate the treatment and then the testing. And then also to use, at the patient level, bilingual and bicultural community health workers or patient educators to work directly with the patients to make sure that they understood the information, and how to make lifestyle changes. So this is just showing what the different interventions are. So at the health system level, we introduced EHR, so electronic medical records level changes. And so first we wanted to understand what is the workflow? How do the providers actually prescribe the medications, and what do they actually do with the patients? So we did interviews with them, as well as doing a review of the literature. And with that information, again, working directly with the providers, we decided that it was important to create a medication order set, so making it very easy for them to prescribe the medications and putting that directly into the electronic medical record system, so within the EPIC system. So we created this drop-down menu. And then after treatment is prescribed, then the next time that patient came in, it immediately would pop up that they needed to be tested again. So there was a lab exam follow-up order set that came up. And then we knew that we needed to create patient education materials for the patients. And so again, we created that, and we put it into the electronic medical record system. So when the doctor saw the patient, they could immediately print it up and give it to the patients. So those changes we made across our whole health system, even though we were working just with one clinic, because it was an important thing to do across all the clinics, because it's something that can affect all of our patients. So all study participants received the information materials. The doctors had access to the EHR tools, the digital tools that we created, and the interventions participants also got the community health worker who helped work one-on-one with them. So this isn't really related to the digital health tools, but this is an example of how we use transcreation. So this is the New York City Department of Health's plate planner, so how to promote healthy eating. And that's part of our programming around gastric cancer prevention, is to encourage healthy eating for the patients who are now at high risk of gastric cancer. So we looked at this and we said, we really need to adapt this for the Chinese patients, because looking at that, for a Chinese immigrant patient, that doesn't look like the way they eat their dinner, for example. So when we showed it to actual Chinese American community members, they were very confused, for example, by the orange. They thought, nobody eats an orange that's sliced in half like this. Why would you put that in the plate planner? So we knew we had to make several adaptations. And so we went through several iterations. We worked with our health department, and this is what we came up with. We changed out the plate itself. We changed out the utensils. Instead of ice water, we introduced a soup, rice, the vegetables, the way they eat it. That community eats their vegetables, and we slice up the fruit. So now that the information they're receiving is immediately recognizable to them, and so that they understand how to make those changes in their diet. So we successfully enrolled 135 people into this study, and have now completed some of the analysis. But I wanted to show you some of the screenshots from our electronic medical record, so the changes that we made. So this is the treatment drop-down menu now that the providers see when a patient has H. pylori infection. And this is the reminders for laboratory testing after they prescribe the medication. So the next time the patient comes in, they immediately, this will pop up, and they know that they have to make an appointment for testing that patient. And this is the patient fact sheet that we created that is in our EPIC electronic medical record system that is translated into Chinese. And so this is our health system's electronic health record data for this study, for the smart sets that we created. So this dip that you see in April 2020, that's our COVID pandemic lockdown. So our whole clinic all of our health system was closed during that period, except for COVID cases. And so no one was writing up using these electronic health order sets during that period. And you can see some of the dips are some of the COVID waves that we had after that, but now we are, again, way up in terms of usage of the electronic medical record tools that we created for our health system. So what we found was that Chinese Americans are the largest Asian subgroup, yet they lack interventions to really help them address significant health disparities. We successfully made system-wide electronic health record changes, working and developing these tools with the providers as well as patients. We know that eradication is complex because of the rising rates of antibiotic resistance, but we saw high usage of our tools and good adherence to medication adherence among our patients. Future steps are, we just completed the first set of doctor interviews on how they like the EHR tools. We will now plan to revise some of the tools based on that information. We learned that not all the doctors were as familiar with the antibiotic resistance levels in China. So we're thinking about reordering the way the treatment list comes up so that it's not triple therapy clarithromycin as the first option, but that it will start pinging people to say, where is this person from, and to consider antibiotic resistance. We're also going to include more training for the providers so that they understand about the antibiotic resistance as well. And I just wanted to end with some key recommendations that I've learned working across these two projects around advancing digital health equity research. So we learned that applying a participatory, so a partnership approach and an iterative process, so continually meeting with the end users to refine the tool is so important to developing a tool that's useful, accessible, and meaningful to the patients. Involving partners from the planning stages is incredibly important as well. They can help identify the problems, solutions, and opportunities for the intervention. It's really important to pause and then do an additional scan to identify other important end users to meet with as you're developing the tool. So these end users can be the hospital administration groups, it can be the community, not only the patients, but also the patient's family members. It's really important to think about all the people that could be affected by this tool. It's important not to just collect tracking information from the tool itself. So like the amount of hits that hits, or the number of logins, or where that person is actually, the information that they're pulling up. But it's also important to do qualitative interviews with them. Why did they only look at information on early childhood education? Why didn't they look at the sleep health information? We want to understand why. Was the sleep information not helpful to them? Do we need to go back and revise how we're creating those videos with those information? We really want to continually refine and make the tools useful for them. It's important to conduct user testing of the beta product, and again, with the multiple users. And then in addition to the mixed methods, formative or planning phase, it's also important to do a mixed methods evaluation. Piloting is so important. it really helps to identify where those problem challenge areas are, who is using the tool and who is not using the tool. So you're making sure that you're rolling out something that's equitable, and to implement the tool with continuous monitoring and assessment to support that refinement and building in time to actually make those changes as you go along. And then just wanted to thank my study team who are bilingual, bicultural, and work very closely with the patient populations and know the patient populations very well. And then the collaborators across both the studies, including our child psychologists and other team members. And this is my email if there are additional questions. And I'm happy to pause here to take any questions that anyone has.